Dr. Fadi Nahab's the director of our stroke center here at Emory, and he's a fantastic colleague and resource, and is all-knowing when it comes to things in neurology, and he manages a lot of FMD patients as well. And I appreciate your time and being here. He's going to talk to us today about intracranial aneurysms and carotid dissections. Thanks.
Thank you, Dr. Wells, for the invitation, and happy to be with you all. I have to say that I was going to start out by asking a question of true or false. When you saw that really good-looking food, how many of you got hungry all of a sudden by that? And yes, I did the same. So we're going to be focusing on basically carotid dissection and the aneurysms, which are an important part of fibromuscular dysplasia. These are my disclosures, not really relevant to FMD. So the goals are really just to understand its connection to FMD, how all of both aneurysms and carotid dissection are connected to strokes, which we all want to avoid, and then we'll talk a little bit about also treatment and approaches to minimize overall stroke risk. So in case, and just to make sure we're all on the same page, when we look at stroke, we think about three main types. The most common is ischemic stroke. Ischemic means lack of blood flow to the brain, usually caused by a blood clot. That makes up about 87% nationally in the US. Then we have the bleeding strokes. Hemorrhagic stroke is bleeding into the brain itself, which is about 10%, and then bleeding around the surface of the brain, which is called subarachnoid hemorrhage, which makes up about 3%. When you think about stroke in FMD, it's really the ischemic and the subarachnoid that we tend to see more commonly. Ischemic because when people have this beating or this narrowing of arteries, such as the carotid arteries and or other arteries that feed the brain, that can actually limit blood flow, and that limitation of blood flow can eventually contribute to lack of blood flow to the brain, which can lead to a stroke. The other thing to keep in mind, as we'll talk about shortly, are aneurysms. And aneurysms can be more common in FMD patients versus those without FMD. And so aneurysms themselves, if they rupture, they will actually cause what we call the subarachnoid hemorrhage, which is bleeding around the surface of the brain. We really don't see as much of the bleeding in the actual brain tissue that I showed earlier. So a couple of things are important to also realize. So when people get scans and you're looking at the carotid arteries, most commonly in the population, for many reasons with the risk factors, the obesity, the unhealthy diets, that atherosclerosis or plaque buildup of the arteries is much more common than FMD. And so when you look at a carotid artery, this is actually, imagine your heart is down here, ultimately feeding blood flow up to your neck. And this is your common carotid artery, and then it splits off into the internal carotid artery, which feeds the brain, and the external carotid artery, which feeds the face and the scalp. And so you can see that when there is a plaque, it kind of looks like this, and then it causes narrowing. I want to compare that to in fibromuscular dysplasia, where we commonly see some level of beading. This kind of in and out string of beads that you can sometimes hear described. As you can see, it's very noticeably different. Now, some people will have beading that's not as dramatic as this, and maybe it's only one bead. And when somebody sees only one bead, especially if somebody, as a radiologist, is reading through the images, they might not even catch it. And so part of it is making sure that people are going through those scans and getting a really good assessment. Obviously, after you have the diagnosis, it could be people are looking more closely at the carotid arteries or intracranial arteries or the renal arteries. But at the same time, this can be very common where we are seeing patients for, stroke or TIA or mini stroke symptoms, and their imaging was called normal, and then we'll see some beading in that approach. So just kind of being aware of that. Now, how does that all connect to a dissection? Dr. Mustafa showed a slide about the way things look like for dissection in fibromuscular dysplasia. Well, in some respect, I'm sorry, in coronary artery disease, in the same way, you can actually have dissections that occur in the carotid arteries. And actually, in the U.S. registry for fibromuscular dysplasia, 42% overall of the registry participants either had a dissection and or an aneurysm. And you can see here about 20% actually had a dissection, 6% basically experienced both a dissection and an aneurysm. And so it's not an uncommon situation with respect to FMD. Now, with carotid dissections, again, similar to what you saw with the diagrams, is you can have basically the inner lining of the artery wall basically tear apart, and sometimes it tears apart and causes a flap, and sometimes it actually doesn't cause a flap, but it causes narrowing because there is buildup of this bleeding in there. And as I think Dr. Laleko was mentioning about the inside out versus the outside in kind of approach, in reality we see both when it comes to the carotid, and some people will have it outside in and some people inside out from that standpoint. And so when it comes to dissection in FMD, it's also important to realize that carotid arteries are the most common when you're thinking about dissection locations, but vertebral arteries, many people don't think about the vertebral arteries, but everybody has two carotid arteries that feed the front part of the brain, two vertebral arteries that feed the back part of the brain. And so we can actually see FMD changes and or dissection related to the vertebral arteries as well. And just to kind of give you a general sense, this is unrelated to FMD, but if we look at people younger than 45 who basically have a stroke, actually 20% of people younger than 45 who have a stroke have evidence of a dissection. So this is actually pretty common even outside of fibromuscular dysplasia, but it's obviously an important thought to always keep in mind. And just showing you here in terms of, this is again a look at the internal carotid artery here. You can see the beading appearance that's seen, but when you have like a longer segment of this narrowing, and this irregularity there, that can actually be a sign of a dissection itself. And here you can sometimes see where the actual fibromuscular dysplasia beading is also around an area where there's actually what we call a pseudoaneurysm that forms around the area of the dissection. We'll touch more on that a bit. So many people ask, well, what should I be looking for? What are those symptoms to keep in mind that could be a sign of basically a stroke or a mini stroke? And the reality is it all depends on what artery is involved, because the part of the brain that's controlled by that artery is ultimately the one that will guide what kind of symptoms you have. So we as neurologists know that the anatomy of the brain is quite discrete. So we know that, if you're right-handed, the left side of the brain is most commonly where your language center sits. Even if you're left-handed, it's still mostly on the left side of the brain. The left-handed people can have language sitting on the right side of the brain a little more than right-handed people. However, the front portion of the brain is where fluency and you're able to speak is. The back part of the brain on the left side is typically the area where your ability to follow complex commands is. And then literally we can pinpoint where the motor control, your ability to move your face, your arm, your leg are actually very discrete entities in the brain that are there. So we can actually look and examine and just hear the story and say, oh, this looks like this person's being affected in this particular location of the brain caused by this artery, and then we'll focus very closely on what artery we're going to be specifically looking very close at in case there's a problem. So some people may not be aware, but TIA, or some people will use the name mini stroke, is what we call for transient ischemic attacks. And as they sound, transient means it's brief, ischemic means it relates to lack of blood flow, and it's an attack because it comes on suddenly and typically comes off suddenly. And so the most important thing for why you want to keep in mind about TIAs is because we like to say when somebody has chest pain, that can be a warning sign of a potential impending heart attack. Well, a TIA can be a potential warning sign of a potential impending stroke. And so when we think about the symptoms overall, and I'll come back to, TIA versus stroke, we've kind of honed it down into this acronym BFAST. So it's really sudden onset of balance trouble. So you're walking just fine and suddenly you're feeling like you're being pulled toward one side. You didn't have any alcohol and you feel almost drunk as you're walking. Sudden onset of double vision or vision loss in one eye or both eyes, so that's the EI. F is facial droop, so if you smile and one side is drooping, that can be a sign. A is basically one arm or leg suddenly goes weak, so we'll typically have people just put their arms up as one side kind of falling down, or the leg. When you lift up the leg, does one side basically fall down? And then S is speech trouble, slurred speech or trouble getting your words out. And T is time to call 911. So again, when somebody is having sudden onset of these symptoms, there's no question. You don't want to go on your portal and say, hey doc, what should I do? No, the answer is it's very important to call 911. Now, are these all the stroke symptoms that exist? The answer is no. These make up about 85% of stroke presentations. But if you are having other symptoms and you're concerned, hey, is this a stroke or TIA? That's where it's very reasonable to reach out to your doctor and say, hey, this is what's going on. Kind of concerned about stroke, but what do you think? And they may tell you, you know what, this is probably unrelated to stroke, or you know what, we need to get this checked out because it could be related to a stroke or a mini stroke. But really important to remember the BFAST symptoms. So why did I talk about TIA? The reason is thankfully, when you look at the US FMD registry, people reported more often having TIAs, those brief warning sign symptoms, than they actually did stroke symptoms. So that's really good news because everybody is more likely to have a warning sign before they have a full-blown stroke. And so if you're having that warning sign and you are concerned for stroke with BFAST, of course, it's the 911. And if your other symptoms that you may be concerned about, again, just keep in mind. Amaurosis fugax is actually this kind of TIA type of presentation where somebody actually has a curtain come down over one eye. And that can be a sign of lack of blood flow to the eye. People think about stroke and TIA as a brain issue. But literally, you can have a stroke of the eye that causes just this curtain to come over one's vision in one eye. So one other symptom I wanted to include here that I haven't included in the past because it's a very common thing. So pulsatile tinnitus basically refers to like this whooshing sound that you can hear your heartbeat in one ear or both ears. Very common within FMD, about 1/3 of people. People oftentimes, I'm sure some of you in the audience have this or have had this, and it's really just the pulsations and the turbulence of flow in areas that may have beating, that may have had a prior dissection, that actually transmit over to your ear, and you hear that. For some people, it can be annoying, but for most people, it's more anxiety provoking because they're like, what's going on? And truthfully, most often, this is not representative of a dissection. This is actually just related to, I'm showing you here the internal carotid artery of an FMD patient, where FMD patients are more likely to have what we call this S-shaped curve. So their blood vessels, rather than going straight up, tend to do this loop-de-loop. And when they do this loop, that blood flow is literally doing a lot of turbulent flow as it's working its way around. And you can hear that as part of each pulsation itself. Women are 3 times more likely than men to have it. Younger ages more associated with it. People are more likely to have associated headaches or neck pain if they have the pulsatile tinnitus and some dizziness. And actually, a doctor can actually listen to the neck with a stethoscope and can actually hear the turbulence as well in some situations with that. Now, shifting gears for the last portion of the talk, just to share about aneurysms. So you can see various examples of aneurysms. And I can honestly tell you that many people, again, get very, very concerned about, oh my God, I have an aneurysm. And I hope from listening to what I'm going to go over here shortly, you can kind of think about aneurysms a little bit more broadly in a big picture way. So aneurysms in the brain are actually less common than other locations in FMD. So that's a good news piece. The patients who tend to have aneurysms with FMD tend to more often, I respect the fact that whenever talks are going on about FMD, it always seems like the women get more of it than the men. Well, here, FMD aneurysms are more likely to be in males. So I just want to highlight that it's not always on the females who are taking the brunt of it. They're more likely to have a history of tobacco use, have a history of high blood pressure, younger age and onset of the blood pressure, and of course if somebody's had a prior subarachnoid hemorrhage, which is the bleeding in the brain itself. So FMD patients with intracranial aneurysms, in one study in the registry, only showed that about 44 patients had intracranial aneurysms that had to actually undergo treatment. And ultimately, 1/3 of those patients actually had the procedure just with the goal of trying to prevent an aneurysm rupture with that. I'm just going to highlight it as an example because many people think, oh, I have an aneurysm, and oh my God, they're going to have to open up my skull and all of that. Well, things have improved quite a bit technologically. So this is basically a patient who has basically this angiogram showing internal carotid artery and the beating appearance here. And then here is an example where, you may not be able to see it, but here's this tortuous artery coming around. And then this is actually what I'm outlining here is the aneurysm. And so we have expert interventionists who basically can snake a wire through the leg or through the artery in the arm and snake it up to that location and can actually deploy a stent across the area where the aneurysm is, blocking blood flow from entering in the aneurysm. And if blood flow doesn't go into the aneurysm, then basically it can't get bigger. And so once you do that, you can see that now where there was an aneurysm, that there is no longer an aneurysm. Now, I do want to highlight that most people do not need any treatment whatsoever for an aneurysm because it can remain stable for decades. Okay, so most often what we do is we will do an assessment, and if there is an aneurysm, we will typically repeat an image within 6 to 12 months and see if there is a change. I'll be honest with you, if somebody continues to use tobacco and they have an aneurysm, it's more likely than not going to get bigger. If somebody has really uncontrolled high blood pressure, it's more likely than not going to get bigger. But those are things that we all have very much control over in terms of exposure. And so we try to highlight, let's be very aggressive. And I can tell you it's very rare that we see aneurysms getting bigger when somebody's risk factors like tobacco and blood pressure are well controlled. I think this might have been talked about a little bit earlier, and so for the sake of time, I'm only just going to highlight here that, as was mentioned before, it's important to have at least one baseline scan when somebody has some suggestion of FMD. Again, that's going to include arteries from the head down to the pelvis. And if I'm seeing patients who I'm newly diagnosing with fibromuscular dysplasia based on something in the head or neck, I'm actually, as an interdisciplinary group, connecting the patients to Dr. Wells and team to basically help with the evaluation systemically. And he commonly, if he sees something where there's potential concern involving neurologic symptoms, again, we help support in terms of addressing things with the head and neck issue. So we really work well as a team together with that. I'm going to skip over this. And bottom line, in terms of the site of involvement and getting the imaging, is have a good conversation with a doctor who knows about FMD, because they will give you the best guidance about what to do as an individual. So last but not least, just sharing a few things about treatments. You already heard me say about tobacco cessation. Even if you don't smoke, but you're exposed to somebody who does smoke a lot, that can affect you. So definitely be careful with who you're around in terms of tobacco use. Regular aerobic exercise has been mentioned. You know, what was mentioned about nutrition, what was mentioned about exercise activities, those are not just good for the heart. Those are good for brain health. Those are good for dementia prevention. It doesn't get talked about much, but all of those things together are going to be great for your overall health itself. As was mentioned earlier about exercises that increase stress on neck arteries, because sometimes doing something traumatic on the neck can contribute to a dissection. So you heard about some of these kinds of examples with that. And heavy weightlifting. Somebody asked a good question about how much weight is the right amount of weight. I honestly tell people the most important thing is if you're straining to carry, and again, one person is going to strain and bear down for a different weight than somebody else, then you're probably trying to do too much. So make sure that you can do something without straining or bearing down, and limit how much weight you're carrying above the level of your shoulder, because that's putting more strain and pressure on your neck. And then you heard about the healthy diet factors. I think as I was coming in, there was discussion about aspirin itself. I will just share, if somebody's had a carotid dissection or a vertebral dissection in the past, we will commonly encourage them to take a baby aspirin, which is 81 milligrams daily. And we do that because people are at risk for having a dissection. And so if you even have minor symptoms or no symptoms and you were to develop a dissection, the aspirin prevents any sort of clot formation that could occur from a dissection that goes up to the brain. Now, again, if you're somebody who can't tolerate a baby aspirin, we don't want somebody having active bleeding or significant stomach pain that they can't tolerate because of the aspirin. So it's an individual discussion about, hey, if you can't tolerate aspirin, are there other strategies to be able to help? Of course, treatment of the neck dissection for the most part is medication treatment, which can be like an aspirin or a different kind of blood thinner temporarily. Some migraine medicines, you'll hear about migraines and headaches a little bit later. Again, we highlighted the importance of controlling your high blood pressure as part of this. And while just having FMD alone is not an indication to be on a statin cholesterol lowering medicine, we're all in looking for good health for the long haul. So the last thing you want is, if you have FMD, to have high cholesterol that's going unrecognized or untreated and building up plaque, cholesterol plaque buildup in various arteries. So it's, again, having that conversation about, okay, we see FMD, but are there areas that have cholesterol plaque buildup that we should care about as well, not just focusing on the FMD piece itself. Endovascular treatments are those treatments that go through a wire, as I was mentioning, that goes through the arteries. These are rarely needed, and we do not recommend them for FMD patients who have no symptoms. Again, frequently it will be referred patients who are so scared to death about, okay, I've got this, what should I do? And the answer is it's going to more likely than not naturally heal on its own, but we're going to keep a close eye on it. If it's not naturally healing on its own, we're going to help you get the right treatment that you need with that. Pseudoaneurysms, again, can sound very scary, but pseudoaneurysms can sometimes just be the remnant leftover of a healed dissection. That's not a terrible thing. That artery is actually structurally still quite good. And then patients with persistent or recurrent stroke symptoms due to dissections, who are on medical treatments but aren't responding to that could potentially need some type of endovascular treatment. But again, that's quite rare, even in our center where we see lots and lots of FMD patients and dissection patients. Interventional treatments for patients with aneurysms, again, older people, none of you are old people, I'm just telling you that right now. And then aneurysm causing symptoms, people will commonly say, well, I've got a headache. Well, I'll be honest with you, it's unlikely that a small aneurysm ever causes a headache whatsoever. So people have the sense of, oh my God, I have a headache, somebody orders an MRI, they see an aneurysm, oh, aneurysm, headache, they must be going together. Actually, more commonly than not, it's actually unrelated to the aneurysm and more likely due to things like migraine. So a neurologist that sees you can help you recognize, hey, this isn't the aneurysm going on. Every headache you have is not a sign that the aneurysm is getting bigger. So those kinds of things are important to keep in mind for perspective. So with that said, hopefully I left a few minutes for questions.